Welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Dr. Justin Lewis. Dr. Lewis is a board-certified foot and ankle surgeon and an expert on complex surgical reconstruction. Today, Dr. Lewis and I are going to be discussing all about the advancements in the foot and ankle from a medical and surgical standpoint and how that carries over into PT rehab. So we have a great conversation about a lot of different things relating to that today. And I know you're going to enjoy this episode. This episode and every episode in season 5 is brought to you by Isophit, my go-to for all things isometric strength training. For more, you can check out the links in the description below. Enjoy. Dr. Lewis, welcome to the podcast. I'm super excited to work with you today, man. Thanks for being here.
Yeah, thanks for having me.
For people who might not be familiar with you or all the amazing things you're doing in your clinical practice over there in Eldersburg and Southern PA, would you mind filling them in a little bit about who you are and all the great stuff you do?
So my background is exercise physiology. So I got my bachelor's, I earned my bachelor's and my master's in exercise physiology. In school, undergrad, we were so hands-on, right? I mean, we're talking about, you're an advocate of blood flow restriction, right? I mean, that is an exercise physiology concept, right? So from using a biodex, right, and doing exercises, learning about muscle fibers, type 1, type 2, like that was part of what we did, putting, respirators on people's faces to study VO2 max, right? Putting EKG leads on people, like all these hands-on things that we did in undergrad and learning about the benefits of exercise and nutrition on health and well-being, that is a bias for me. And I think it's a positive one, we learned all those things and we were hands-on, that I expanded that and got my doctorate in podiatry, right? And then residency in foot and ankle surgery. I have this pride, in my foundation, my undergrad education about exercise physiology, because there's so much that ties in when we do surgery, especially with orthopedic type and podiatry, musculoskeletal things. And I was always a little annoyed, when we look at a hard science, we had some students are biochem majors, right? And they can sit in a classroom and have no personal interaction all day, get great grades, get great scores, test scores, get into med school, and they're a doctor, right? Fine, yeah, and they can earn that. And I always had a little gripe because exercise physiology was considered a soft science. It wasn't a hard science that they consider a hard science like biochem and chemistry and biology. But we were always hands-on. Like we physically touched people to help them, and test them and see what's going on with their body. And I think that's helped me throughout my path and my career, to really dive into, pathology and how to fix people and how to do it efficiently and, with the background of science. So currently, yeah, I'm practicing as a podiatrist and I do foot and ankle surgery, a lot of sports medicine. We have a high volume of dancers that come into my office. So we have a little subspecialty there that we've done with dancers. And, of course, the, other things that we do, there are diabetics, that are losing, toes and getting amputations. And there's still biomechanics involved with that and physical therapy and gait training. So that's a big part of my practice right now.
Yeah, no, that's awesome. I love that background. It's very unique to, meet someone who's doing foot and ankle surgery, who has a background in ex-phys. And to your point, it's often considered that softer science. And I got that a lot when I graduated because I did an undergrad in exercise science similar to you. And everyone was like, well, what are you going to do with that? That didn't really teach you anything. And it's like, no, like you still have to know the anatomy. You still have to know the physiology. But it's not just knowing the underlying mechanisms, it's actually applying it into something that's going to have, a notable effect on the body. And, yes, you do that to a certain extent in biology and chemistry and that sort of thing. But to your point, it's a lot different when that person is like sitting right in front of you and you can actually see the progress and see the change for yourself over time, right? Like there's something to be said about being able to put hands on someone and like see physical change over a period of time. And I think that's something that we tend to lose a lot in the medical field, right? Like we start looking at our cases and we start looking and thinking in terms of like numbers or percentages or, diagnoses, and we start to kind of forget that people element. And I found, at least for myself, and it sounds like you saw something similar, when you get trained and learn in that people focused environment, that just tends to be how you practice from there on out.
Yeah, that's something I pride myself on, right? When we look at research, right, and we look at case studies, yeah, we're looking at, the power of the studies, right? The N equals 2,000 subjects, 5,000. The patients, N equals one, right? That is something that I learned, is that the patient, they don't really care what the research shows. They want you to fix them. N equals one, it's them, and they want a success, right? With certain cases that I've done where we've, explored different techniques, like I don't have the big volume on some of those, and if I presented that, yeah, people would say, well, you don't have enough cases to show that it works. But for me, the two patients that I did it on, they're happy, and it helped them. So, for them, like you said, it's when you have that one-on-one with a patient, we're always taught, you treat the patient, not the x-ray, right? And if you tore your Achilles, you probably wouldn't want me to analyze it, assess it, treat it surgically the same as a 70-year-old man. We just don't do that. So that's why we do try to look at the whole picture with a lot of patients that we see. Yeah.
Completely agree. And I think that's an essential element and one that often gets missed. And to your point about being holistic and looking at the whole patient, it doesn't just stop from a surgical standpoint. It applies throughout the entire rehab process, right? Like we have to keep our eyes on that patient from the day that they come to see us to the day that they're finally discharged. And even beyond discharge, I like to still kind of reach out and stay in touch, with patients and see how they're doing, because that's feedback to me. And I mean, from a
Sure.
surgical standpoint, that's feedback to you, right? Like, hey,
Yeah.
reached out to this patient, did this procedure 5 years ago. They're still loving life and happy and doing everything they want. That's a success. So I think that relation is essential, but having that relation, going beyond just like the initial examination or evaluation and extending, throughout their entire care time is also often missed and essential as well. And, it certainly sounds like you've been doing that for years now, or at least everything I've heard about you from the past is that you are that guy and you do that on the regular.
Yeah, it's always exciting, when you get sometimes the tough ones, right? I mean, they can be frustrating for sure, but it makes you really dive in and use your brain and think outside the box sometimes. And so no, it's stimulating, right? You get tough cases and tough patients, and sometimes it's very stimulating to help give them answers. Sometimes we succeed, sometimes we don't, but it's the nature of the game.
No, I completely agree. And on those tough cases, the importance of collaboration really
Mhm.
comes up. We were talking about that earlier, right? Some of these
Yeah.
cases we both see, they're very complex. And it's like, I don't really like how things are going right now, or I don't really
Mhm.
know what the best answer is right now. And that's where conversations between, PT and surgeon or AT and surgeon or whatever, professionals are involved in helping the patient. I think those conversations become absolutely essential. And, to that point, from a surgical standpoint, you're doing incredible work in the foot and ankle. And my job is, to a certain extent, to protect what you did and make sure I don't, damage anything or mess something up for the person in front of me. And I think that's an essential piece. And I think that relation is really essential for us moving forward as well. How do you kind of go about, from your standpoint, on that PT or rehab professional relation with you, and how do you kind of work together and collaborate on a patient's progression?
Yeah, so I am very pro PT, right? Because of the background, right? The exercise physiology background. A lot of my classmates, they're PTs now, right? And so I have that very high level of respect for PTs. Having said that, it's with when physical therapists come to my office and want patients, referrals, I do listen to all of them, right? And but one of the key things that I wait for is I wait for the patient when they go to come back to my office and talk to me because they tell me things, right? And so that is important. So for me, like I can't really assess and see, I'm not going to shadow certain PTs in their clinic and, make sure that they're doing what I want from a patient. But some of these patients, they come back to me and they say, no, it wasn't stimulating. It was boring. The therapist barely touched me. They told me to do 50 of these exercises and they'll be back in 10 minutes. And then when they came back, they told me to do another 50 of a different exercise. So I wait for feedback from patients. And that's how I kind of assess and see who my referral source is for physical therapy. Just like any, profession. Some are better than others, right? Even surgeons, there are some that, you might not want to refer to or get second opinions from. But yeah, the communication is key. So that is number one, how I find my go-to therapist, right? Is patient feedback, really. And then of course, we're looking at outcomes too, right? Definitely. So the communication, the notes, the questions, right? I love it. Like when, physical therapists email me, right? Like I'm always checking my email and, messaging me, anything, texting me. I love it because, with anything, if you have a question, yeah, I can easily answer it quickly, right? So I do appreciate that as well, with that collaborative and the communication. That's very important. And and just like anything, the comfort level, right? To make sure that I'm confident that this patient is going to be taken care of. And I kind of always tell the younger training students or residents, you should know your physical therapist on a first name basis, right? I mean, I always say, you call me Justin because we're all professionals and we're all, it's not this complex here, but we should be knowing each other on first name basis, right? We shouldn't just be blindly giving a PT referral for some of our surgery patients. Like we have to know who they are, what they're going to do. And then after a while, you kind of your comfort, where you trust them. You're like, you got free reign. I will tell you when you can do whatever you want, right? Because patients always ask me as well, and also PTs. There will be a certain time where I look at the patient, physically, and I say, you know what, whatever they want to do, I'm comfortable with. They can do anything. Then the question is when, what determines that, which I'm sure is your next question, right?
Yeah, well, just to recap there, first off, it's interesting to me when you're talking about what you look for in a PT, a certain certification or a certain credential was never mentioned there, right? Like there
Mhm.
are a lot of PTs I know and I respect them so much for this, but there's this like pursuit of like a letter game after
Mhm.
or after your last name, right? Like how many different certifications and credentials can you get? And I'm probably guilty of it myself to a certain extent, but having a certain certification or a certain credential or taking one class on something doesn't instantaneously make you the best, provider for someone. And
Sure.
even if you have that knowledge, if you can't treat the person in front of you like a person, then you're doing them a disservice ultimately, right? And to your point about the whole walk away after exercise, if you're in a rehab setting where you're seeing 4 or 5 patients simultaneously, you're probably not best equipped for some of the complex post foot and ankle type of injuries. If you can be one-on-one with them, even for at least half an hour, at least half the session, you're much better equipped. You're able to provide a much better level of care. And ultimately, you're able to get to know the person in front of you. You mentioned before that you work with, dancers and a lot of different athletic populations. I've never grown up dancing myself, but I've worked with dancers. I've worked with gymnasts. I've worked with athletes that do sports that I don't do or didn't do myself. And one of the most important things of that was the conversations I had with them, right? Like, just because I don't have a background in the sport myself doesn't mean I can't learn about it and learn how to structure and tailor my rehab progression to them. You also mentioned about patient interest, and I think that's one of the best things to get to keep them coming back to rehab. Like, make them enjoy exercise, make them fall in love with the process of improving their
Mhm.
own, function, for lack of a better way to put it. And if you can make things seem like, the sport or activity they're trying to get back to they're much more likely to enjoy it than, oh, this is just the same 10 boring basic exercises that I probably could have found on Google all over again. So I absolutely love those points. And, to your point on communication too, I try, and I'm probably not perfect at it, but I try and keep that communication train going, because the more time I practice, the more I realize how little I actually know. That might be scary for someone to, listen to out of context, but we take our, boards, we do all these different exams and prove that we know what we, are supposed to know. And then you get into practice and nothing ever presents like the textbook said it would. And it's like, well, what now? So having conversations as professionals is how we move the needle forward and how we get people better ultimately, in my opinion, right? We call it the practice of medicine for a reason. We're all still learning at the end of the day.
Right. I mean, to focus on that point, one is as a healthcare professional, if for the dancers, right? Just I didn't dance, knew nothing about it. My respect level was probably even keel, while my wife trained professionally as a ballet dancer. That's why I learned about it, and it was for them extremely difficult. They're a high level athletes, like that is some tough stuff that they're doing. And she taught me a lot, my wife did, who's also a podiatrist, about dancers and their psyche, their mindset. They're no, they're high level, just like any other high level athlete. But I had to learn it, right? And yeah, I didn't have any background in it. When I grew up, I played baseball, through high school. And then when I moved to Maryland, in Florida is where, I did high school and undergrad and grad, and baseball, basketball, football. That's Florida. In Maryland, when I get these 13-year-olds coming in the office, with their overuse injuries, it's the spring and the fall, right? I'm sure you see it too. Overuse, they're getting back. What sport are you playing? Oh, I'm playing soccer, and then I'm playing lacrosse. I'm also doing football. I do a little bit of tennis. I'm like, wow, right? So, like in this area, I mean, sports are like a big deal for a lot of these young kids. And sometimes, yeah, it is overuse. And I do have lectures with these young kids about trying to be the next professional athlete, but not resting and icing and rehabbing like professional athletes. They just want to go, go, go. So there's that, just learning the sport, right? Lacrosse, right? No idea. In Florida, it's booming now, but when I was in high school, we didn't know about lacrosse. We move up here, yeah, it's lacrosse. And of course, then I get the athletes coming in. I have to learn what they're doing, what the biomechanics are, what kind of shoe gear they're wearing, what's the most common injury, for the lower extremity. So all those things. And then the other thing is, we all have our limitations. Any great doctor, any great PT, any great surgeon knows their limitations. The question is, when do you stop at your limit and refer out, right? That's a biggie too. And I don't see it. We see it in many times we don't. But, even for me, there are some things that I don't know. And you find that person, right? You can do your own research and try and dive into it. But sometimes you're like, no, I think I know somebody who's going to be great to assess you. And so that's always a thing too. We don't always want to keep and keep and keep, and get nowhere, because then the patient gets frustrated and like, I don't know what we're doing here. So it's knowing, yeah, when each provider knows their limit and when to find the next level person, which is important too.
Yeah, and that is probably one of the biggest takeaways, if not the biggest takeaway that we've ever shared on the podcast, right? Like, if you aren't sure and if you don't know, you have to do what's best for the person in front of you. And that might require you to check your pride, right? Like, there's certain things I don't rehab. Like, I have not rehabbed someone following an arthroplasty in over a year. I'm not the guy for your knee replacement, your hip replacement, your shoulder replacement. Like, could I do it? Probably. But if I haven't done it regularly and that's not where I'm focusing, my time and effort and education, I'm probably not the guy for you. And that's, to that point, that's why we have surgeons that specialize in different things, right?
Sure.
Like, The surgeon that does your foot and ankle surgery is not the same one doing your neurosurgery, not the same
Mm-hmm.
one doing your elbow surgery, not the same
Right.
one doing your hip arthroplasty, right? Like we have specialists for a reason. So I love
Exactly.
that point. And, along those lines too, if you get something that's complex and you're working with it, you mentioned before that you're pretty comfortable with PTs that you like and trust doing, whatever they want to do, but that comes with, great power comes great responsibility, right? Like just because I have someone and I don't have any restrictions doesn't mean I go 0 to 100. It means,
Mm-hmm.
hey, this is
Mm-hmm.
our green light to progress them back and not just go, from one end of the spectrum to the other. I feel like a lot of people struggle, at least in the exercise and rehab world. A lot of individuals will struggle with that progression back and what that looks like for someone, right? Like we know the end goal, which is the
Mm-hmm.
sport, whether that's
Mm-hmm.
dance or lacrosse or whatever. We know where they're at now when they come to see us, but that building steps, what does level 1 look like? Level 10, level 50, level 100, and building that full progression back. I think the first 10 out of 100 levels tend to be easy for most rehab professionals. After
Mm-hmm.
that, it's a little bit more scattered. How do we take someone from range and strengthening into jumping? How do we take them from jumping to running? How do we take them from running to excel and then decel and then change direction? And all those things are further amplified in the foot and ankle cases, I believe, because
Yeah.
it all starts from the ground.
Yeah. Yeah. That's why. Yeah. I mean, you do a lot with the knee. With the knee, we know it's a hinge joint. There's some rotation there. We know which muscles are there. We know which nerves are there, which tendons. We do know that the pelvis, the hamstrings, the tight Achilles can affect knee function. When you talk about, oh, with foot and ankle, it's so complex, right? We have so many joints going on. So it's hard to pinpoint like, when you could do something for this. I think it depends on the surgery, what you did. But with the ankle, we know it's a hinge joint, right? And then we go down to the subtalar joint, which is a gliding joint. And then the talonavicular joint is a ball and socket joint. And then you go back into the gliding joints with the tarsometatarsals and back to hinge with your MTPs and your toes. And we know if there's a pathology somewhere along that closed kinetic chain from the toes to the subtalar joint, it can affect your ankle function, right? Your mechanics, your bombing. So there's so many things that come into play. If we did an ankle fracture and we want to know when can they get back at X number, whatever weeks or X functioning, but if they have subtalar joint arthritis, we know that's going to affect the ankle and the biomechanics and the rehab as well. So that's why it's just there's so many things moving parts, with the foot and ankle, and that's why it's hard to just pinpoint, when should this go. With the knee, I think you're pretty, with ACLs, I think you're pretty well versed, depending on if it's an isolated ACL of when your timeline is, and you probably can get there close. But yeah, with foot and ankle, I think we're all over the board a little bit. For me personally, I am an advocate of early motion, early things. And that's, I think again, that's my bias with exercise physiology. Eccentric loading, that was a big part of our learning, right? The benefits of eccentric loading on muscles and the muscle tendon unit and how beneficial it can be from, strength and hypertrophy. And so we want that, right? So that's why I'm an advocate of getting people moving. And I've broached on this with the Achilles, is that, traditionally, we have always, fixed them. How you do it now, and then we would plantar flex them cast, right? Because surgeons wanted to protect their repair. And I remember there's one attending I had that told me he casted them in neutral, and he said, you want tension load on that tendon, and it made sense, right? You're already eccentrically loading that tendon on day 0, right, and getting them to neutral. Now you have to trust your repair as a surgeon. You have to make sure that your repair is strong enough to hold that. But if they're casted in neutral, I mean, there's no cyclical loading. Unless they fell, then yeah, something could fail. And then the question was, well, how long did you do that? And when you get them out of the cast, there's so many things there. But to piggyback on that, but to cast someone with their Achilles tendon rupture in plantar flexion for 6 weeks, I think is detriment to the patient. I don't. I think they could still get a good long-term outcome, but if you're talking about an athlete, right, we're not waiting for a 6 month. We want like a 3 month outcome, right? We know with athletes they got to get back quicker, and so again, it comes down to treating the patient, not the X-ray, or treating the MRI. And yes, a 60-year-old patient that works at Home Depot and he fell off a ladder, yeah, I'm going to treat them probably a little bit differently. But that athlete who's very active, he even wants to play on the weekends, no, we're going to do things a little differently. And so that's why we kind of change our focus there on when we get people back. Some people are just very still conservative, and I've touched base on techniques, technology. The technology has gone up with everything in our lives. I mean, going back as a resident, I remember I joke with some of the doctors that the iPhone, I think, just came out when I was in my last year of residency. So we had cell phones, no internet, right? We had these little pocketbooks with every single medicine in like 4-point font to figure out what to prescribe, how much to give, what the doses. We didn't know. We literally open up a book when we're on the floor. Now you look at your phone, everything's there, right? You can just look it up and just see what dose you're going to prescribe this, what protocol you want. So the technologies have changed, right? So then you talk about surgeons, right? We talk about, can some surgeons embrace technology techniques? Some do more than others. I tell you, they'll embrace the cell phone technology, right? But they won't sometimes embrace it in their OR, which is interesting to me. I doubt there's many surgeons with flip phones. There might be a few, but they all want the nicer phone, and they also want the nicer car that can park itself and drive itself. They want these technology cars, but they don't apply it to the OR. But even the ones that do, right? The ones that do embrace new techniques, new technology that can get patients back on their feet quicker, some of them still hold back on the rehab part. They'll do the new technology, but they still want the same post-op protocol. They still want the 8 weeks of non-weight bearing, despite the advancement in the technology. And I found that a little interesting that the technology go up, but then for some surgeons, their rehab protocol stays on a flat line still. It should follow that the progression of rehab should follow the technology and technique, improvements over the years. But it seems like it hasn't. Well, maybe it has, but maybe I don't think it's going parallel. I think some people are just still holding on.
Yeah, no, I love that point. That's really interesting. As we advance surgically and we get stronger holds on, to your point, the tendon repair. If the tendon repair is stronger and I'm more comfortable and confident in it, then why am I delaying starting rehab when I know it's going to hold, right? And on top of that, I trust the PT, I trust the rehab professional doing it. Where if I say, hey, don't do X, Y, and Z, like, hey, don't maximally stretch that Achilles repair on day one and don't stretch the heck out of it for, 2-3 months, then, I should be good to start earlier. And you mentioned start early over and over again there. What does early look like for you following some of these foot and ankle procedures? Are you having people start within 24, 48 hours, or are you waiting like a week or two still? Where is the line on early, and what does that look like?
I'm usually 1 to 2 weeks, we tell patients with foot and ankle surgery, it hurts. I mean, gravity's pulling the swelling down. There's so many nerve endings to the foot, right? They're all, coming down the leg into the ankle, and then they're splitting into different branches. The foot swells, it hurts, right? So that first week, these patients they're not feeling great, no matter what we do. And so I doubt that they would be, happy to go to PT. So I usually wait 1 to 2 weeks, and it basically is just to get the swelling and the pain level down. And after that, we get them going. Initially starting off with just getting the muscles to remember what they're supposed to do, right? I tell patients, from day one, I want them wiggling their toes, right? We want those muscle units firing, no matter what I do, right? So 1 to 2 weeks is usually my standard. Depending, right? If it's a fracture, and we have internal fixation in there, yeah, we want to limit how much we're doing to some degree. Um, but again, that varies too by the surgeon. Sometimes surgeons don't want you to touch it for 3 months to make sure the bone is healed. But then there's debate with that too. There's debate with everything. That's why we do what we do. I mean, you hate to say that there's a right and a wrong, but it's to each their own. It's just, with patients, what's interesting is that, when you look at, the Achilles, we always beat up the Achilles so much. And we've kind of talked about it a lot with the Aaron Rodgers thing, but, when you talk about like, non-operative versus operative, right? There's always that debate. Well, a lot of the non-ops do well. But, interestingly, when you dive into research, you find that most of these studies that were non-op came from Europe, right? And you have to think about some bias there, right? The lifestyle of Europeans is a little different than Americans. When you talk about return to function, well, what's function? You talk about quality of life, and they might be happier there than they are here. I don't know. Americans are go, go, go. They're like, fix me, right? My hardest patients are dancers, athletes, CrossFit people. Those are my hardest patients because they want to be fixed like now. They got something to do tomorrow. So the non-op ones, the studies for Achilles were, majority of them are based out of Europe, where it's an observational type of medicine. Like England is observing, they observe, they document, they treat, they don't intervene as much as they do as America. Then, well, maybe we're intervening too much and we're doing too much, So, but those people have done well. But again, if their quality of life is just to, walk and be okay and active, so there's some bias there with that non-operative versus operative. And as for the operative, when we talk about the Achilles, like I said, the muscle physiology is the big component there. Most of the studies, when we looked at, failure, if it failed, right? Surgeons are afraid that you are going to mess something up, right? That if you do something too soon on my Achilles, I'm going to blame you. And that can't happen, right? When, spine surgery, rotator cuff, slap repairs, if something fails, the first thing they'll look at is you. What did pieces do? Did they do something too much? But a lot of the studies for Achilles tendon failure, when you look at what fails in a surgeon, it's usually the knot. When we're tying these things together, the weakest part of a surgeon's repair is the knot that he or she used, because it can unravel. And then you look further into the studies, is it from force loading, which is not as accurate for daily life to have a load of failure study. That's if someone fell and they dorsiflex their foot. But how often does that happen? It could. Cyclical loading, right? That's what we want to look at. We want to look at cyclical loading. At what point does that fail with the Achilles tendon? Because that's walking, right? Cycling is the study, right? Cyclical loading, and then increasing the force. How much walking? And that became more accurate. And from that, then we've determined, well, with the Aaron Rodgers thing, which is not a new surgery, it's not. If the weakest part of a surgeon's repair is the knot, why would we tie the knot in the weakest part of the tendon, which was the rupture site? Like we finally figured it out. Like if my weakest part of my repair is the knot, and I tied it into the rupture site, why would you do both there? That's where the advancements came, right? From studies, right? We did cyclical loading studies, and we decided, well, don't put your knot where the rupture is. Tie it above or below. And they did, and they found that there was a stronger load of failure and cyclical loading failure. And then they advanced it even more to, well, why don't we just tie it away from the rupture site and put it into the calcaneus, right? And that made it a stronger structure. So when you talk about, so that was a long discussion about when does a surgeon feel it's comfortable for you to start doing something? If that, strong repair is strong enough for regular cyclical loading, which is walking, it's not going to fail, right? 2 weeks out, if that patient have protected walking, everything's not going to unravel, right? So 2 weeks after an Achilles repair, yeah, it should be moving. There should be some. Now, you're not going to go crazy maximal dorsiflexion, but we do want eccentric loading, right? We want something, whatever you can do to get that neuromuscular activation of the muscle unit to fire so they can get rehab quicker, right? I mean, there's always been that debate. Some surgeons have said this media frenzy with Aaron Rodgers is going to give false hope to other people and other patients that think that they can get back. um I understand that too. You don't want to give people false hope. And then there's the thought that it takes 3 months for a tendon to physiologically heal, right? But that's without advancements in physical therapy too, right?
Right.
In 3 months, if that tendon is healed, then they should go. But that doesn't mean we, as a surgeon, we wait 3 months, it's healed, now you can do what you want to do. No, I do not believe in that, right? We want 2 weeks rehab, do something, right? Loading, anything, and then increasing the function and the goals. And then in 3 months, it's healed, their function is a lot better. Then we want them really getting back. I don't know if they're going to get back to sport then, but that's my thought process with getting people back quickly. I do not think walking and cyclical loading would make everything fall apart. Patient compliance is always there. You have to always remind the patient. It's up to you too to remind them and encourage them and make sure that they're staying focused and not doing too much as well.
Right. That's where the individualization and getting to know your patient and where they want to go, that's where all of that comes in. And, along those lines too, as we mentioned, athletes, you mentioned dancers do some incredible stuff that I'm never going to physically do. If you're listening, if you've never seen a ballet dancer go on point, look it up. And then just consider what has to go into the foot and ankle complex to make that happen. It is
Right.
absolutely wild. So if we want people to get back to that and they want to get back quicker and they don't want complications to happen, as you mentioned, we need to evolve our approach from surgical standpoint and from rehab standpoint. We need to find ways to be better, do better, and deliver better for the person in front of us and, provide them the service that they want. And if we stay stuck in, well, this is how we always did it, this is how we used to do it, then we ultimately do them a disservice because these sports require such extremes that, you look back at some of these past research studies, a lot of people wouldn't be able to get back after some of these procedures just due to the amount of limitation or the length of time that they were out. Like it takes a toll on the body physically, not even to mention mentally what it does to someone when, as you mentioned earlier, up here, it seems like a lot of kids love their sports and that's their identity. Well, try taking that away from them for 6 to 8 months,
Yeah.
even a year.
Mhm.
There's a lot of mental struggles that I see that tie into that. And I'm not a mental health professional by any means, but it's something that I think we need to be aware of. You mentioned on the PT side too, advancements there. You mentioned eccentric loading. I'm a huge proponent of BFR. I'm also a huge proponent of NMES, neuromuscular electrical stimulation. In the most recent Achilles rehabs I've done, I actually use that to both heads of the gastroc, and I have a little trigger button that they hit, and when they calf raise, it fires the NMES.
Yeah.
So we can add a little bit extra activation on the concentric, the eccentric, or we could just sit there and hold it because isometric loading also has a great spot for tendon rehab and for getting people to actually feel and contract muscles, hold for prolonged periods of time, develop strength in certain positions, and so on that way. But, if we were still just doing heat, ice, ultrasound, and ankle pumps, then a lot of these athletes wouldn't be getting back. So I
Right.
love the point that we have to evolve, and I love that, our clinics should look different as well, right? Like, you should not walk into a PT clinic and see, 10 pounds is the heaviest weight they have if your goal is to get back to high level sport, because I'm sorry, but that's not enough to adequately stress the system and load the system to get you back to sport. And same thing from a surgeon standpoint, right? Like, if you walk into the surgeon's office and they're like, look, this is not really my kind of case. I've never really worked with someone your age before, your demographic before, that sort of thing. That's where, as we mentioned before, those referral out things come into play, right? Like, you as a surgeon don't touch shoulders, but I'm sure you probably know a great shoulder doctor over there
Yeah.
in Maryland. So finding ways to, evolve as clinicians and evolve in our practice and how we do things is certainly essential. And I love your taking your points on that. I think progression is essential in order to move from one spot in rehab to the next. And it's one of those things that, as you mentioned, the foot and ankle is a very gray area. We might not have the same amount of literature as we do for something like the ACL, or clinicians might not have the experience, or it could just be, the amount of different factors at play. As you mentioned, there's a lot of joints, there's a lot of muscles, there's a lot of things in a small area. So when it
Yeah.
comes to, criteria for progression, or, maybe one of these athletes is at that
Mhm.
return to sport point, are there certain numbers or metrics or tests that you like to look for? How do you like to see the progression done from like a criterion standpoint?
Yeah, I mean, subjective is important, right? I mean, you have your, I mean, you do both, right? The objective data and the subjective. I can tell you that, I'm not taking out tape measures and measuring, diameters of things in my office. I just don't, I'm, looking at range of motion. I am looking at patient feedback. What I wouldn't want is that if objective data is lagging behind, but their subjective, functioning and their response of walking and pain level is advanced, you don't want the objective data to pull them down, right? Like we don't want to solely rely on objective data and say, no, I don't think you can move to the next level because, you still got a lot of swelling here or there. I don't know. So relying on that patient feedback is extremely important, right? I mean, but having said that, you have some patients that will be a little bit more cautious. You hate to say scared, but yeah, fearful that they're not sure if they're ready. And then that's the psychological aspect, of course, which is, we do coaching too, right? We encourage people. And I've had to tell patients that too. Like there are times where after X number of weeks, I tell them, if you walk, you are not going to mess something up. If you walk, if you fell, possibly. If you ran, jump, possibly. I want you to walk. You have to tell yourself it's safe to walk. Walking is a subconscious thing, right? We know, like we don't have to think about it. We just do it. Now, if you've had an injury, pain, surgery, you will change the way you walk. And I tell patients, you have to now consciously have your brain tell you to walk evenly and walk as normal as you can, which is still hard. And sometimes they need the feedback from someone visualizing it like you. So there's always that subjective, encouragement, of what the patient can handle, what they feel comfortable with. And it's us, encouraging them that I think you can. And there will be to the point where after another X number of weeks where I feel everything's healed, I'm like, nope, free reign. You can jump up and down on this, and I don't have much worry that you're going to mess something up. And I give them free reign with PT to do whatever they can to get them back to their level that they want. So the objective data, the subjective data, it's all there. It's the the psyche and the mental capacity and the encouragement and a lot of that falls on you all. I know a lot of times PTs are waiting and they're like, well, what did your surgeon say? Did they say that you can do this now? And some of them will reach out to me. Sometimes we have some tough, complex ones and really don't know. And I'll give them the green light on many things.
Yeah, no, that's a great point. At the end of the day, the patient is the only one that can feel what their body feels like and how it's moving and how they're functioning compared to past functional level. So the subjective is absolutely essential to your point on when things feel good, but also when things don't feel good, right? Like maybe I do all my objective testing and all the numbers look great, but that athlete looks at me and says, hey, look,
Yeah,
I don't feel ready yet. Well,
right.
that puts me in another hard place where it's like, well, the numbers look good, you're good to go.
Mhm.
But if they say they're not ready, they're not ready, and I'm not going to rush them back. We're going to take steps and take time to build their confidence and get them to that point where they are ready to go.
And then it's making sure that we're on the right track of what they had to begin with, right? Because maybe they have something doesn't feel right And maybe it's in a little bit different area that we were focusing on. And that's when we have to have, when we hit goals, you're right. We don't want to just say, all right, you're good to go. Let's, if they're like, no, something doesn't feel right, then you might want to, perk your ears up a little bit and say, okay, well, explain. Sometimes we'll find something that we've missed from the jump, right? So
Yeah, no, I completely agree. And I think that's where the combination of subjective and objective data kind of combines together to form like, your ultimate criteria for progression and ultimate, discharge from care, because I want all my patients to get to the point where they don't need to come see me anymore. Like I want them to be independent and able to handle whatever life throws at them on their own. And ideally not come back with a second injury to that area or really another area. It's not always possible, but we do our best.
mhm.
And I think, again, it's one of those things where people will talk all the time about like, hey, there's 50 or 60 different metrics I look at. There's 5 different metrics I look at. I don't think that there's one right or wrong way to do that. It's just a matter of, do you want to be the individual who never looked at something, or one that,
Mm.
assess something in some capacity, right? Like, even if you're still doing, the traditional model of calf testing of, 30 single leg calf raises is your like 5 out of 5 calf strength. Like I would rather do that than never look at calf strength. If
Mhm.
all I can do is that, I would rather look at that than nothing. So
Mhm.
really just finding ways to, incorporate both of those into their progression, and considering all the other aspects of it too. As we mentioned before, holistic, I'll throw a GAD-7 in there different times. It's a quick 7-item self-report, outcome measure that people can fill out themselves relating to the anxiety they have about, their
Mhm.
injury. And it's like,
Mhm.
it takes 30 seconds. It's their subjective information. It gives me an objective number. I can track that over time. There's a lot of easy, low-hanging fruit stuff here, I feel. Has there been any other different criteria for progressions that you look for? And how do you kind of balance the criteria with the timeline, right? Like, say someone looks phenomenal at
Mhm.
3 months, but normal, timeline is 4 to 6. Do you let people go back a little bit earlier if the criteria is good?
I do. Yeah. Yeah. Um, Depending, of course, on what was done, right? I mean, we had one patient, 16 volleyball player, right? So the sport, right? That's a little different. There's a lot of squatting, a lot of dorsiflexion on the ankle, a lot of jumping. She was a tougher case, but we did a ankle arthroscopy debridement, and I was more confident in her just getting back as quick as she could. Um, if she had a ligament tear or a tendon tear, then I probably would wait for that good strong 3 months before I let her do a lot of jumping. Um, then you have, again, it's sport specific, right? I mean, you have baseball players and there's a lot of pivoting, twisting, angled running, right? They're leaning, but not a lot of jumping, right? So, I probably would vary a little bit. I'm not talking about months of variation here, but based on the sport specific injury, it would fluctuate a little bit. But the bottom line is yes, if I think they're ahead, I would let them get back earlier if they've met all their goals. Some people heal faster than others. We know that, right? Some people just take a little bit longer. Some people swell more than others, and that's a limiting factor for many people is just getting into their proper athletic shoe. And some people just bounce back and they're quick to heal. So yeah, each person's different. But I'm not gonna, like I said, you hate to put everybody in one broad category, right? We want to be patient specific and sport specific.
Yeah, no, completely agree. And I love that individualized approach. And, as you mentioned, everyone heals differently. I've seen a number of people who swell up a lot more. And there's too many factors that could possibly feed into that to really, stop and like say it's this one or it's that one, right? Like, there's so many different factors that impact healing timelines and, that sort of thing. So I don't think there's one big thing there, but to your point, everyone does it different. So we need to individualize how we do and what we do for every patient that walks in. Justin,
Agreed.
I feel like we've had a great conversation covering a lot of different advancements on your side of things and how we kind of function as clinicians. Do you have any kind of other thoughts or remarks or anything we might have missed as we're discussing today?
No, I think we hit most of it. I mean, our again, we all have the main goal, the same goal, no matter what your degree is, right? Athletic trainer, ATC, DO, DPM, DPT, MD. We all have the same goal. And the same goal is that patient, that specific patient, to get them back to normal, right? Pain-free and normal. Everyone has the same goal. And the thing is, how do we get there? Who do we trust? And at what point do we say, I don't think it's going right? And that is sometimes a frustrating part for the patient more than anybody. And I think it's up to us, all of us, right? No matter what our degree is, to really dive in and say, when is it not right? Are we missing something? Pull someone off to the side. Hey, can you look at this? Can you treat her next time and make sure that I'm checking all the boxes or I'm not missing something? I've done it. I've had some cases where I treat them and I'm like, you know what? I don't want to get tunnel vision. I don't want to make sure that I want a second set of eyes on it. And the patients appreciate that. I think if you hold on too long, 6 months go by, it's just frustration. So for me, yeah, I've offered second opinions to patients sometimes. I'm like, I think we should get a second set of eyes, just make sure I'm not missing something. And again, that's great for them. And the same thing with, the PTs, right? If you think something's amiss, maybe encouraging a second opinion as well. Maybe a second set of eyes have to see something. If we're hitting roadblocks, we are not we're way behind schedule. That's very important too.
Yeah, no, I completely agree. I love that point, the importance of collaboration and the importance of, just recognizing that it's okay to have someone else look at it, right? Like when we're in school, I don't know about you, but I had people check my work all the time, right? Like if we're palpating, hey, check my palpation. If we're doing a new skill, hey, am I where I want to be here when I do this? So if that's how we've always learned and we've established that we're all still learning, we all don't know everything, then why have we changed the standard now that we're just clinically practicing instead of students when in reality we're all lifelong students?
Yep, we're always learning. I'm always still opening my book, so that's what we have to do.
Nature of the beast, for sure. Justin, for people who want to find out more about you and your clinical practice, or possibly even set up, an appointment or evaluation with you and your team that way, where can they find you at?
Yep, so 2 locations, Eldersburg, Maryland, and also Shrewsbury, Pennsylvania. Office number is 410-795-2155. Call. We're always taking new patients. Like I said, we are always taking second opinions. We're taking dancers. They're coming in from, different states, trying to come and have us evaluate them as well. Social media, Instagram is probably the most popular, which is Justin Lewis _foot surgery on Instagram.
Awesome. So you're officially out of the MySpace generation then, Justin.
Yeah. And Facebook, I'm like, not as much either.
For sure. Love that. We will link to all of that in the description below too. That way, if you didn't quite catch it, you can just click there. Justin, I really appreciate your time and everything today. Thank you.
Yeah, thank you.
Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.